Hello friends, in this video I am going to demonstrate you how to use Indocyanine Green for proper evaluating the CBD and to prevent injury of the CBD. So this is a 40-year-old female and we are performing laparoscopic cholecystectomy. Here a small stab wound is given over the inferior crease of umbilicus and we are introducing various needle, and after that we will do this irrigation, suction and hanging drop test to make it sure that we are inside the abdomen. And then here insufflation is started, and this will be the laparoscopic cholecystectomy with the Indocyanine Green and the method of using the platelet to identify all the structure, biliary structure, and to perform the safe cholecystectomy. So we can see that slowly insufflation is started. Here we are keeping the preset pressure at 15 and actual pressure is slowly building up, and homogeneous distension of the abdominal cavity is started. So, as we know that minimum 1.5 liter or maximum 6 liter gas is required to distend the normal human abdominal cavity, and we have approximately 2.5 liter gas already in and waiting for few more seconds, so that appropriate amount of the gas will reach. Now various needle is taken out and we will enlarge the incision to 11 mm, that is a smiling incision either side, and this is a 11 mm incision to introduce the first port. We will take a mosquito and stretch the skin as well as dilate the obliterated vitreointestinal tract, and then this trocar will be introduced. We always apply little betadine at the tip of the trocar, and now the gas is reattached and the flow rate is increased to 10 liter per minute. So now we will put the epigastric port. This is Jiffy sternum. So the right thumb should palpate the Jiffy sternum, and we will put just half centimeter below. This port will be the main operating port through which you can use the harmonic or hook or the Maryland or the flageolet, whatever you will hold in the right hand, this will go from this port. So initially it should go perpendicular, after that we will go towards the right and will pierce the membranous part of the falciform ligament. So this is the third port will be introduced now, and third port will be mid clavicular line just below the costal margin or just below the fundus of the gallbladder, and this third port will be introduced by your assistant, because he will hold the fundus of the gallbladder. So he can put this third port. You can also put, but we are giving here for the assistant to introduce this port. Always we should cut the skin along the Langer's line, so there will be the minimum scar. And this is the third port. This is 5 mm and this will be used for the retraction of the Hartmann pouch, either anterolateral or anteromedial. This should also go perpendicular. We should avoid making a track, and this is introduced. Now fourth port will be 7.5 centimeter lateral and 7.5 centimeter below the third port on the anterior axillary line, or you can put at the level of umbilicus on the anterior axillary line. But sometime in the obese patient, putting on the level of the umbilicus will keep you little away, and retracting the fundus towards the diaphragm will be little difficult. So, it should be 7.5 centimeter lateral and 7.5 centimeter below the third port on the anterior axillary line. So, all the ports is in the position, and then we will start cholecystectomy. Now, in this patient, already 45 minutes before the surgery, on the peripheral vein, we have injected 2.5 milligram of the Indocyanine Green. Indocyanine Green is available in the India by the brand Auro Green, and it is a lyophilized powder. So, it is available in 25 milligram powder, but we have only taken 1 ml and 2.5 milligram is injected 45 minutes before the surgery with the same IV cannula which is used for induction. And now we start the surgery. Here the fundus of the gallbladder is retracted towards the right shoulder, and first we should hold just above the adhesion, and the first step is to do all the adhesiolysis. After that, Hartmann pouch is given anteromedial traction, and this is posterior peritoneal dissection, which is started at the level of the angle of the body of the gallbladder and cystic pedicle. You can use hook, you can use scissors also. Here harmonic scalpel is used. Rouvier sulcus would have been here, but in this patient there is just a white fissure, there is no clear cut sulcus. So, this is the posterior peritoneal dissection by giving anteromedial traction, and now this is anterolateral traction to separate the anterior peritoneum at the same level, and now this is the dissection of the visceral peritoneum over the cystic pedicle. So, once the skeletonization process is complete, after that, here we are using harmonic for this skeletonization process, and this posterior window is made by the placelet. This is placelet, this is very good instrument which you can use for demonstrating the entire anatomy with the ICG, because it is a peanut which is made by the Johnson and Johnson Ethicon. We can see this is CBD, and this is the tented CBD. Here is the common hepatic duct, and this is CBD, and above is cystic duct. So, now we will take a Maryland, and this is the anterior window which will be formed between the artery and duct, and always we should try to open it parallel to the tubular structure. and this is a window in between the artery and the duct. Once you turn the ICG mode, after that you have a different mode in the ICG like contrast mode, ENV mode. So, we should try to use all the modes for the proper examination of the entire CBD anatomy. This is the posterior window, you can see this is the cystic plate which is enlarging, and this is the posterior window which is in between the artery and the inferior surface of the liver. So, in the critical view of safety, you should have two clear cut structure entering into the gallbladder with two clear cut window. This is the anterior window which is in between the artery and duct, and this is the cystic pedicle. There are little fibrinous, these are the fibrous trabecules which you can cut, and this is the anterior window. Now, this is the ICG mode. There are different mode, that is CSF mode, ENV mode, contrast mode. This is contrast mode. In the contrast mode, you can see that CBD and cystic duct is looking white color, because bile will take the ICG, and this is cystic duct, and here behind is the artery. And this is the Maryland which we are lifting the duct and artery. This is posterior window, and this is the anterior window. So, these are the various modes. Once you have the platelet, you can retract it and you can remove all the adventitious tissue over the common hepatic duct and the common bile duct. Artery won't be visible. If you want to see the artery, you have to inject right now. So, we can see this, all the anatomy is clearly visible, and this you can lift the surface of the liver, and if you will go by the telescope more nearly, then right hepatic duct, left hepatic duct, common hepatic duct, cystic duct and CBD all is clearly visible. So, this is cystic duct, this is common hepatic duct, this is CBD. If you will use the ICG properly, then 5 times less injury of the CBD is reported. Normally, CBD injury, including beginners and expert both in laparoscopy, 0.5%, but after using ICG it is 0.1%. So, this is the CBD, common hepatic duct, cystic duct, all is clearly visible, and after that there is a very rare chance that you will damage the CBD. So, now all the anatomy is clear. Now, we are clipping, the titanium clip is used here to clip over the cystic artery. And the two clip is enough if you are using the harmonic scalpel. And here 3 clip is applied over the duct. At least 3 millimeter of the cystic duct should be left near the CBD, so that you should not do the lateral clipping. And distance between first and third is 9 millimeter, and distance between first and second is 3 millimeter. So that you can cut with in between the second and third. After that, here we are using harmonic scalpel again in the right hand. So that this is the cutting the cystic artery, and then cystic duct will be separated. After that, you should keep on giving anteromedial, anterolateral traction and maintaining the proper areolar tissue plane. Gallbladder will be separated from the liver. So, first you should cut the peritoneum, then only you will get a proper areolar plane. Once the 50% of the gallbladder is separated, then the light cable should be down in the 30-degree telescope, so that you can see better the bed of the gallbladder, and then separation will be much easier. Once you reach to the last part, the fundus, near the fundus, then the fundus grasper of the assistant is removed, and then traction is towards the right iliac fossa. And before last cut, we should have final inspection. So, at that time again ICG is very helpful to find out the duct of Laska or cystohepatic duct, or any abnormal leak of the bile, and we can see all the structures are fine, there is no bleeding, it is dry, there is no bile leak, and everything is fine. And then we should do final cut. So, before final cut, it is always better to have final inspection, and then the gallbladder is finally separated from the liver. After that, we should have one endo bag, and ideally the gallbladder better should be put in an endo bag, and then this is an endo catch, and then the gallbladder will be taken out, keeping inside the endo catch, so that there will be no any contamination of the port site, no infection, and if there is a rare chance any malignancy, then there will be no any metastasis also. So, this way you can perform the safe cholecystectomy, and I will highly recommend to use ICG in every case, so that your complication rate will be low. So, thank you very much for watching this video. This was just a simple case where we have demonstrated how to properly use ICG and how to interpret anatomy by delineating all the structure with the Indocyanine Green. So, thank you very much for watching this video. Have a nice day.